Hello and welcome. I am Steve Clements, editor-at-large of The Hill. Our conversation today is going to explore lessons from the coronavirus pandemic as they relate to access and affordability of medicines. I'd like to thank our sponsor, Tefa Pharmaceuticals, for their support of this event. Deeply interconnected global pharmaceutical supply chains are being stress tested for the first time on a major scale as a result of the ongoing COVID-19 pandemic and national tensions that have concurrently flared. As trade tensions have risen, so have national security concerns about limited access to the active ingredients in many drugs, many of which are produced in India and China. While the U.S. still has a significant global share of production, and I've got a chart to show this, as this graph from the Center for Drug Evaluation and Research at the FDA shows, the United States hosts about 28% of the manufacturing sites that produce active pharmaceutical ingredients, or APIs for short. You're going to hear a lot about APIs in the show today, which then gets turned into tablets or capsules or injections. The remaining 72% of manufacturing sites are located overseas, which is why it is not unreasonable to look at what policies make sense for reweighting certain equities in the drug production ecosystem. But that would require study, potentially massive investment, and a reordering of regulations around pharmaceuticals production in order to be competitive with other drug production centers. We're going to spend the next hour examining and having a deep dive into what all this means and how to ensure reliable access to affordable medicine during and after a pandemic and maybe before the next one hits. We have a fantastic lineup of speakers to explore this topic, including members of Congress and experts in the healthcare space. Before we get underway, a couple of housekeeping notes. You can tweet us at @TheHillEvents using the hashtag, this is a cool one, TheHillRX. Very original. We are broadcasting live and we'll be taking your questions throughout the program. As with any live stream, you might occasionally have a little trouble with the video. I do all the time. Refreshing the page should in most cases fix the problem. My first guest today is a member of the Senate's Health, Education, Labor, and Pensions Committee and a member of the Foreign Relations Committee. He's an outspoken advocate for federalizing our medical supply chain during the fight against COVID-19. He's also joined bipartisan efforts to ensure the safety and supply of pharmaceuticals in the country. Senator Murphy, it's great to see you again, and thank you for joining us on this important topic. Look, I mean, COVID-19 hit. A lot of people saw it coming. Some people saw it coming and said they didn't say they knew it was coming. But, you know, we had paralysis, a kind of heart attack when it came to PPE gear and the sense that we didn't have what we need in this country. What are you trying to do about it?
Well, I mean, it's not, entirely constructive to keep reliving history, but it is important to remember that there were many of us who, at the beginning of this crisis, knew that we were going to need to pre-order supplies. We were going to need to invest in training. There's a meeting on February 5th in which Republicans and Democrats in the Senate are begging this administration to start a major down payment on supply chain, one they refused to engage in at that point in the process. And so we've been playing catch up ever since. I've been, very concerned about the outsourcing of our medical supply chain for a long time. Senator Rubio and I have been working on this for over a year. And I think it begs some really important questions moving forward. There are benefits, of course, to having an international medical supply chain, right? The connections that we have economically to the rest of the world can lead to a more stable globe. But we have seen how exposed we are when 100% of some absolutely necessary medical gear, whether it be the PPE that we didn't have enough of early in the crisis, or the drugs and the vaccines that we are going to need in the future, are all sourced outside of the United States. So I think we're going to have to build a much more nimble, much more flexible system in which we still rely on international supply chains, but we resource ourselves with stockpiles much more aggressively, and then we have reserve capacity here at home so you can at least quickly gear up to make some percentage of the components of drugs, the hard medical supplies, or the vaccines that we ultimately need to beat pandemics.
So, Senator, I may sound naive in my question, and I would just love to kind of get just a little more nuance on this, because when I hear the words federalize the supply chain, it sounds almost like nationalize, and it almost sounds as if almost like a command and control calculation. And I'm just interested because most of all of this that we're talking about there is private sector. You've got private companies, private firms that are often multinational companies that have have, assets all over the world. And I was talking to the health minister of Sweden today about how she is worried about vaccine nationalism, for instance. So I'm just interested in, are you talking about federalizing for a short period of time? And how do you get the equities right between that national need and national direction, like the Defense Production Act used selectively in times of crisis, versus the realities of the decisions that private sector companies have to make?
Well, I mean, we're in a national emergency right now, right? I mean, we have 1,200 people died yesterday. We had 860,000 people who filed for unemployment last month. I mean, this is a dire national emergency. And right now we have to err on the side of saving lives. And so, yes, I believe that for the time being, that means federalizing the supply chain at the very least of PPE. And what that means is not the federal government coming in and running a private manufacturer, but going to manufacturers and saying, hey, listen, for the next 3 months, you're going to be in the business of making masks or face shields. And we're going to pay you a fair price to do that, but you are going to be part of meeting this national commitment. This is what we did in wartime. We are not doing it now, even though this virus is killing more people than many of the kinetic wars we've been engaged in have killed. So I just think the administration has totally abdicated its responsibility by not taking a more forceful hand and paying manufacturers what it costs to make this equipment, but effectively mandating that they make it for a foreseeable period of time. Frankly, there'd be tons of manufacturers in Connecticut who would be glad to get that call. I have a lot of manufacturers who are ready to start turning their production lines over to making medical supplies, but they don't want to do that unless they have a guarantee of how long that's going to last and what they're going to get paid.
That sounds very compelling. I'd like to show you a chart, Senator, and I've shown this to Senator Warner and others because, just trying to get a fix on, particularly on APIs. And this short chart, which was from 2019, shows that China has about 13%. Let me just finish here. 28% of 510 facilities are in China. China's at 13% when it comes to the rest of the world of manufacturing facilities by region. The United States is larger than that. The rest of the world is there. So I know there's been a shift and almost a doubling over a decade of capacity in China. But when it comes to sort of looking at APIs and that dependency and those key drugs that we need, do we need to shift it back from China, or is it other parts of the world that have you worried?
I think this is about a broader exposure to a global supply chain. I think we have to be most worried about China these days, especially given the way in which our relations are deteriorating on a daily basis. But you just never know when things are going to get rough between the United States and any other nation, such that they could hold that kind of leverage over the life and death stakes of a pandemic. And so, again, I think it's a combination of measures. I think it's about resourcing some of this manufacturing from start to finish. I think part of it is about developing the capacity to scale up. So effectively paying some manufacturers in the United States to sort of hold reserve manufacturing capacity. So if we need them to start making a particular drug or a particular device, that they have the ability to scale up. And then lastly, just doing a much better job of stockpiling. There's certain things you can stockpile, there are certain things you can't, but we clearly didn't have the necessary stockpiles at the beginning of this pandemic.
Look, it's super clear to me that you've thought carefully and strategically about the many component pieces out there. But it used to be you'd say the word supply chains and people's eyes would, they'd glaze over and they'd run out of the room and say, they'd get on their cell phone. But it's a hot topic now. I mean, you mentioned supply chains and people show up. But what we're also talking about is a kind of committed industrial policy, which may involve pricing, it involves investment. It means, what's the science and R&D ecosystem around it? What are the jobs around it and the training? So there are lots of pieces that come around the kind of initiative you're talking about. And I guess my blunt question to you is, does the U.S. have the capacity today, as you see it, to put those pieces around? Because it's an ecosystem, it's not a flip of a switch.
No, I think you're very right. This is about a broader conversation about creating a new American industrial policy, a brand new American industrial policy, because we don't have one. And in Europe, in Japan, in South Korea, they have robust profitable private sectors, but they also have much more integration between the private sector and government, much more planning that happens with all of those players at the table. I do think that there is a new recognition amongst many Republicans who would have been anathema to industrial planning 10 years ago, that there is no way to confront China in the new century without having that greater integration. Just think about the technology side of the equation. 5G is just the tip of the iceberg. On 6G, on advanced battery, on AI, China is going to be able to lap the United States because of that integration between government and the private sector. And so we're going to not necessarily have to copy what China does, but we're going to have that conversation and that coordination, especially on research and development, be tighter between public and private sector in the United States and with Europe if we want to be able to meet China where they're going to be over the next 100 years. And my sense is that there are a lot more Republicans who want to be part of that conversation. The pandemic, but also China's general rise on technology exports have woken them up.
Senator, you and I are both foreign affairs junkies, as I know you know. And, you know, I was talking, as I mentioned, to the Minister for Health and Welfare in Sweden, and she said, you know, we should be coordinating among trusted allies. We should be talking more deeply about how to help each other in dark days. Where does the reliance and maybe the restoration of trust with allies who also are going to be part of this global supply chain come into the picture you're talking about?
Well, you know, the president got fleeced by China when he entered into a trade war with them without our allies. There is just no way for the United States to be able to effectively combat China's unfair trade practices alone. And of course, the Europeans have the same interests that we do. They do not want Chinese product safety standards becoming dominant across the world for the next 50 to 100 years. And so what is so tragic about the foreign policy disaster of the last 3.5 years is that there was an opportunity for the United States and Europe to set some common economic policy to go into trade negotiations with China jointly. And because this president decided to fight China, to fight Europe on everything, we weren't able to avail ourselves of that opportunity.
Well, Senator Chris Murphy, it's always a pleasure to talk to you, and thank you for sharing your work on talking about what we need to do with supply chains in times of crisis. Thank you.
Great. Thanks, Steve.
My next guest is no stranger to international coordination, investment, and innovation. He's all about that. Three elements are central to this discussion. Adam Bowler is the CEO of the U.S. International Development Finance Corporation, otherwise known as America's Development Bank. Prior to that, he served as director of the Innovation Center at the U.S. Department of Health and Human Services. Adam, it's great to see you again, and I really appreciate you coming in because, you know, we were just talking to Senator Murphy and said, hey, we need a plan, you know, we need to onshore, we need to bring in and get control of this. If there's one part of government that has the capacity to do that, it's yours. So can you share with us your strategic map of how you're thinking about what America has to do with its supply chain and its health network dependencies, if you will?
Yeah, absolutely. So one of the, I think, lessons so far in the midst of this pandemic is that the United States really needs to have, in some cases, domestic capability, and in some cases, a whole bunch of redundance across allies. And so there was a discussion, and this goes back a few months right in the midst of this, because we saw areas of concern, and there was a discussion with Department of Defense, where they knew they have the ability to do what DF does around the world. I mean, we focus on emerging countries to drive development and then U.S. foreign policy. And so DOD said, look, these are issues that we know. Agent Schutz was noting the same thing. And he said, you guys, in essence, as you described, you're a development bank. So that's what we look like. We look like a bank, very similar to it with a real development veneer around it. And so they said, we don't really do loans. And DFC has the advantage of two things. One is massive expertise in doing exactly that. And then the second is the fact that we are an international agency is important too, because we're able to look across the world and say, hey, it may make sense to put this, some of this in the United States or invest in that, but not everything, right? Because redundancy can be just as important with allies, as I said in the beginning. So let me give you a few areas we've been looking at and examples. One is when we look at these areas where we have an interagency team, it includes DOD, state, HHS if healthcare related. And the first thing that Secretary Azar at HHS mentioned was generic pharmaceuticals. And so, he obviously indicated if we're always reliant on other countries in 90% of the drugs that we take, you could end up in a huge situation, whether intended and nefarious or whether not intended and nefarious. So that was a key one that HHS identified that DOD also was interested in. Another example, just a slight example that I'd use is we ramped up ventilator capability very quickly, and it saved lives in the United States. It also helped us to help our allies. So there is another example where if we hadn't had the domestic manufacturing capability, where would we be? Luckily, we had it on the ventilator side, and so we were able to pick it up. But we've looked at other things like, for instance, gloves. I mean, 80% of rubber gloves are made in Malaysia right now. Now, we have a great relationship with Malaysia, but what if Malaysia ran into a huge issue, massive expansion of COVID, and those factories shut down? Those are the kind of areas we want to look at because we want to make sure that always Americans are secure and safe, whether it's PPE, whether it's generic pharmaceuticals.
Adam, are you now, as you sit and look at this, and I really appreciate the outline you gave for how you were looking and reacting to the pandemic when it was hitting, but now we're going to need, I would imagine hundreds of millions, if not billions of vials of, all of the equipment that surrounds vaccines. It's actually, the physical holding, injecting, transporting stuff. And again, I'm just wondering, have you pre-positioned some of your thinking in anticipation of the kind of global vaccination requirements we're going to have?
So the way I'd separate out DFC versus Operation Warp Speed is DFC is kind of investing in the medium to long term, right? Because it takes us a little while. So if we're thinking about, let's say, onshoring generic pharmaceutical manufacturing, that won't happen tomorrow. It'll happen over a period of time. Operation Warp Speed is focused on the immediate, and that's where it's the partnership between DOD and HHS. I do know that they are working 24/7 to manufacture and be ready. In fact, I was just hearing about a facility that McKesson runs, whose job is to take and package all of the specific ingredients that you need beyond the vaccine, whether that's needles, vials, et cetera. So I know that, and DOD is leading on the sourcing there, and I know they're pushing very hard. And then also thinking about distribution of the vaccines themselves, because a lot of times you need refrigeration, et cetera. So they're not easy things, but I think in combination with our private market and then what DOD will do on that side, they're focused heavily on it.
Adam, let me show you the same chart that I showed Senator Murphy and it basically has a rough picture of API production around the world. China's got in this by last year, 2019, about 13% of that production. The U.S. 28%, the rest of the world 59%. Now I know that a lot of API production in the U.S. has shifted to China and India, but what should that map look like? What should be our goal when it comes to thinking about what we would feel safe and what we can trust and what you're going to need to finance, whether it's with trusted allies or in the United States? What do we need that map to look like?
And just as an aside, right, that's just APIs. That doesn't include your KSMs, right?
Right.
And I assume if you showed that chart with KSMs, you're going to see the United States go really, really low in terms of your key starting material. So, I think, I don't know that we have a specific number because I think it depends a little bit on which pharmaceutical, et cetera. But I do think that you should see a significant shift to the United States or to critical allies, particularly in the region, right? So you could see some in Western Hemisphere countries as well. And then you have redundancy. And I think, one of the interesting things about manufacturing, you think when it all moved to China back a while back, labor was more of an arbitrage than it is today, which isn't to say that Chinese labor isn't cheap. But I think that manufacturing technology has also improved massively. So your efficiency and the U.S. lead in manufacturing technology can help bridge some of that gap. And so where DFC has been focused on it is, where are areas where, because if you're going to take anything that you have in China or anywhere else and move it somewhere, there's going to be a particular cost associated with that. And so number one, how can we help in terms of that cost? And then how can we work with states, the federal government, municipalities, to make the cost advantage not a huge cost advantage. So how do we, or other agencies of government, in terms of how to identify this being a sustainable thing that doesn't go away after a period of a loan or something like that, because that's important to us. I mean, at the end of the day, if you think about what DFC does across the world, what we drive is we drive U.S. policy, whether that's development, whether that's bringing things on shore to ensure that Americans are safe. But we invest in sustainable solutions. And I think that's important. One of the nice things about DFC is that we return money to the American taxpayer, right? We reduce the deficit. But beyond reducing the deficit, I think it's very important when you have sustainability, because things stick. And so that's been the most important. And so, I think you'll see more shift because it's a huge policy. We are a component of that, but it's a whole of government approach, working with also states and municipalities.
Adam, I don't know if this is something you can talk about, but I would love to just give our viewers a quick snapshot of the international work you do. You've mentioned it a few times, and the fact that you're doing this, because right now, if you were to look at the kind of, what I would say, surface noise out there, the international system looks troubled, trust looks complicated, but beneath it, there are these working functionalities that sometimes people don't see. So I'd love to kind of understand, and maybe get a feel for your, international coordination. Is it where it needs to be? Is it healthy? Do you feel it's solid?
Yeah, absolutely. So I'll give you a quick background on us and then what we do. So DFC is a relatively new agency. We used to be called OPIC, O-P-I-C. Sure. So it was confusing. I always thought it was the oil
Overseas Private Investment Corporation. Bad name.
Yeah, that's right. That's right. So that we got rid of that confusing. I didn't have to open every meeting with that were not the oil consortia. But I will say, so Congress passed something called the Build Act, and Senator Murphy, who was just on before, was heavily involved in that. And one of the best things about this policy is that Congress recognized that you have a huge win for the United States. And here's what I mean internationally, which is we invest in developing countries to promote our foreign policy and American values, and we make money for the taxpayer. And so what was happening, and this is what the senator was referring to a little bit, is you obviously have China that is investing over $1 trillion in their Belt and Road Initiative. And what they focus on is undo Chinese influence. That's their goal. We tried that 200 years ago. It was called colonialism. It doesn't work very well. So how do we approach it, and how is DFC different? Is because of this new agency, we're able to say we are the alternative to autocratic, closed, non-transparent investments. And I will tell you, at a meeting, and I've met dozens of heads of state in my role traveling to developing countries, and I would say 100% of the time, what they say is, we didn't want to take that money from China or Russia or wherever. We wanted an American alternative, but there was none. And I'm able to be that alternative. And so we are now a $60 billion, we're kind of the money of the U.S. government in a way, with some other partners, but we are the development bank of the United States. And the flexibility that was given to us, bipartisan by Congress. I mean, the wonderful thing about this is not a Republican ideal. It's not a Democratic ideal. It's an American approach. I was confirmed voice vote by the entire Senate. And that meant a lot to me because these are shared values in what we do.
Right. I think it's great. We're taking questions from the audience, and we have one for you from Daniel. Daniel?
Hi, this is Daniel Faraci, CEO of Grassroots Political Consulting in Washington, D.C. My question for you is, are there programs other than BARDA that are available to identify domestic manufacturing capability?
Sure.
And is it you?
Yes, I am a program besides BARDA. So I'll divide up a few areas. One, so you know, is that you have BARDA that is making investments. The NIH is making investments on lab testing manufacturing. So they have a separate Congress gave them a separate power to do that. DOD makes purchases if it has to do with manufacturing for national security. They have the ability to guarantee purchases and make purchases. And then think about our domestic authority is really making loans and investments to support manufacturing as long as they're to ensure the safety and security of the American people in the context of a pandemic. So that's where we're going to focus. And you can often see folks working together. We do a lot with HHS, with BARDA. So, BARDA could say, we want to make an initial investment, but we're also going to pair this with manufacturing authority. So we can work together, and sometimes we can serve as a concierge there. We're happy if it is relevant to us to sit down and say, hey, this is what makes sense. And by the way, if there's private market capital we can identify, we'll move out of the way too, which is a great outcome. So our job on this, if we see an opportunity and it fits and it makes a difference for the American people, is to try to figure out if there is a way to move it forward. And if that is DFC as a part, that's fantastic. If it's us just helping, that's fantastic too.
Well, Adam Bowler, CEO of the U.S. International Development Finance Corporation, has been part of my favorite, one of my favorite discussions here. I learned a lot. I'm glad you're there doing what you're doing. Thank you so much.
Thank you so much for having me on. I appreciate it.
And now it's time for the sponsor perspective portion of our program. Before we get going, a quick clarification. While I'm conducting this next interview and the questions are mine, the content of the portion of today's program shouldn't be considered editorial. With that, I'm pleased to welcome Brendan O'Grady, President and CEO of Tefa Pharmaceuticals USA. Brendan, you and I have discussed the issue, the trauma America went through as COVID-19 hit, the stress that put on PPE, on pharmaceuticals around the world. And I'd just love to understand that from your perspective, what was America exposed to from the COVID-19 crisis that we should be worried about?
Well, I think that what became apparent during the COVID-19 crisis, especially the early days of the COVID-19 crisis, was the reliance on foreign manufacturing for our pharmaceuticals, many of our pharmaceuticals, especially generics, a lot of the active pharmaceutical ingredients, which we call API, certainly the starter chemicals, and also the personal protection equipment. In the early days, I don't think that was really something that most people thought about. And then all of a sudden we started to see supply disruptions as a result.
Well, I think when you saw that, you saw basically the seizing up of concern. It wasn't just in the United States, it was really globally. Now, Teva is the largest generic manufacturer in the world. Did you see the similar patterns in all of the places you operate, or did anybody get it, really better than we did?
Well, I would say some places got it better than others, but I think that, again, in the early days, nobody was really quite sure what the extent of the COVID-19 pandemic would look like. Nobody was really sure of the lethality of the disease. And so I think there was a lot of just reacting in real time. And of course, there was this kind of mentality around hoarding and trying to protect oneself or one's own country. And so we did see supply disruptions as a result, as countries shut down borders, not just for pharmaceuticals, but personal protection equipment and other necessary items as they figured out how to deal with the pandemic. I think the United States did a very good job at dealing with it. The crisis averted over time. But even today, we still have shortages of some critical medicines that is continuing to be a result of the pandemic.
Now, as a result of other discussions I've had with you and members of Congress, other pharmaceutical leaders out there, I've always found it fascinating that members of Congress did not know that active pharmaceutical ingredients, that very few of these, if any, were really produced in the United States, and that there's this dependency on the globe, just the way things have become. What is the right balance between looking at how you restore trust in a global network and bringing some of that productive capacity back in the United States? How do you get the equities there right so that trust is restored and we don't, but yet we're still global?
It's a great question, and it's really at the crux of the matter. I'm a child of the 70s and the early 80s, and I remember growing up south of Buffalo, New York, and Bethlehem Steel closed down. And steel manufacturing moved offshore. Of course, the clothing industry largely moved offshore, and pharmaceuticals, especially generics, is really no different. I think that in order to maintain a sustainable profit margin, most manufacturers have had to move manufacturing to lowest cost countries. So when you think about how do we secure the national drug supply or the U.S. drug supply, there's really three major things that I think we can do. I think we can reshore or bring some manufacturing back to the U.S., especially those critical medicines that are on the critical medicine list. But to do so, we have to have a sustainable pricing model for those to be profitable. The second thing we can do is we can increase the numbers and the quantities in the strategic national supply, especially for those coming from foreign sources. And I think the third thing that we can do is we can look at manufacturing in allied-friendly countries, such as Canada, Europe, and Israel, and other locations more friendly to the United States, and maybe away from countries that are more adversarial or geopolitically unstable.
So how much of that could be done? And I mean, I hate to get into the details with you, but I know you deal with details, every day. So when you look at that pricing, those pricing models would really interest me. I mean, that's in part pricing. It's also the marketplace. It's regulation. So this isn't just something you can wave a wand at. You need to have serious planning and strategy for a reshoring campaign, I assume. Has anybody kind of drawn up what that kind of plan might look like?
Well, I think there's people that are looking at it. We're certainly in dialogue with the government about some of these strategies. I mean, if you think about, I'll just take Tefa, for example. We make over 600 medicines for the U.S. market, and we make about a third of them here. But the other 2/3 we make in other locations around the world, and we do so because that's the only way that we can make a profit. And I think that most people would probably be shocked to know that if you look at our vast portfolio, about 40% of that portfolio we sell out to wholesalers for about the price of a cup of coffee. And there's this narrative that's out there about how expensive medications are, and I'm not going to debate or deny that there are some medications that are very, very expensive, but overall 90% of the utilization in the United States is generic drugs, and the vast majority of those generic drugs are very affordable. We had a product that we made in New Jersey, and we made 1 billion doses a year of it. We lost $14 million a year doing that. So we moved it to Eastern Europe to one of our manufacturing plants there. And now we turned that $14 million loss into a $20 million profit. So there's a $34 million swing. Now, to maintain and keep that product here in the U.S. would have been about 25 cents a dose. So something very reasonable. We're not talking lots of a huge expense, but the market just wouldn't support it. So that's why we had to move it to Eastern Europe. So when I talk about sustainable pricing, those are the kind of things that I'm talking about, is getting some kind of a model and working with the government and other policymakers to assure that we can make those critical medicines here and do it at a reasonable profit margin so we can assure not only the security, but also the sustainability.
You've also talked, Brendan, about I think it's called the National Strategic Stockpile, but I might have that wrong. But when you kind of look at it about how it can be smarter, how can we be looking at the sort of top drugs that the nation needs? What kind of steps would you like to see the U.S. government take, and how would you, as a leader in the private sector, look to partner with that?
Well, first, I'd like to, acknowledge that the federal government is looking at this on a daily basis, and it's something that they're very focused on. There's been a couple big deals announced in the press not too long ago, and I think that as we look at this, Teva being one of the largest generics manufacturer in the world and one of the largest pharmaceutical manufacturers, is we have infrastructure and we have the regulatory, the know-how already in place to do this. So I think there's Teva and there's others that could step in and make a pretty big impact immediately, especially with some of the critical medicines. We have several plants here in the United States with varying technologies. We're looking at bringing some of those critical medicines back and are having that dialogue with the federal government. But again, what really this all hinges on is, can we do it? And will we be able to recover our costs and make a reasonable profit in doing so and moving it from another location?
I think sometimes the U.S. public doesn't realize how large a firm you are, that you're I think 1 out of 10 every drugs that are out there. I may even be understating that for a moment. But I mean, I think the broad sense is you have a huge footprint in the United States. You also have a huge footprint globally. As you look at kind of the state of global affairs, and I call it sort of the need for high trust networks in a time when trust is stressed out. I'd just love to get your sense, your North Star, if you will, for your company. I know you run Teva USA, but I mean, when you're kind of looking at these networks we need, are you worried down the road about the stress on these networks?
Well, of course, I'm certainly worried, but I think that Teva has done an outstanding job at managing all of it. As you mentioned, I'm president and CEO of Teva USA, but I also have North America as part of my responsibility. So that includes Canada, and I sit on our executive committee. So I am very involved in global decisions and the global nature of our job. Or of our company. As you mentioned, 1 out of every 10 prescriptions in the United States is filled with a Teva product. And just to give you a sense of scale, that's about 370 million prescriptions a year and actually billions of doses. Just in 2018 alone, Teva was responsible for $42 billion in savings to the U.S. healthcare system, and actually $6 billion we put directly back into patients' pockets. So we are a very large player in the healthcare system, and we take that role very seriously, and we're very focused on making sure that we can get medicines, not just critical medicines, but medicines to all of our patients. We can keep our manufacturing going, and we can work through some of these supply challenges.
Brendan, just final question. One of the things that I've been thinking about, and I've enjoyed my conversation with you in the past, is are we prepared for the next time something hits? It's one thing to kind of be dealing with COVID today, but what about the next pandemic that hits? And a lot of people worry about that. Do you think we are incorporating the lessons we're learning from this now in a serious way to be prepared for the next round?
Well, I think as a society, as a government, and certainly Teva as a generic and branded pharmaceutical manufacturer, that we are learning lessons and we are prepared. I think that, as we look at our manufacturing network, certainly there's things that we can do to play a role in the strategic national supply. Certainly there's some products, especially the critical medicines, that we can bring back to the United States. But I think the other key component to Teva and our strategy is that we're somewhat diversified around the world with a lot of manufacturing in Europe, some manufacturing in Israel, and other allied-friendly countries. So in a way, that helps us de-risk a little bit some kind of geopolitical event, a natural disaster, or war happening in one location, and having all your manufacturing in that one location. I think the lesson learned would be as an industry, or particularly the governments, is that we have an understanding if something like this, or when something like this happens again, how we want to react and make sure we get medicines to not just Americans, certainly that's important to all of us, but to everybody in the world that needs those medicines, as events unfold.
Well, listen, I just want to say thank you for being as involved and engaged in these important issues. And we talk about them, and sometimes we throw stuff around very carelessly, but I know you're at it all the time, every day. So thank you so much for your time. Brendan O'Grady, President and CEO, Teva Pharmaceuticals USA, thanks so much for your time and for supporting today's program.
Thank you.
And now it's time for our panel of experts who can shed light on what we are getting right and wrong in our medical supply chain. Dan Mendelsohn is the founder of Avalier Health, a healthcare consulting firm, and Aisha Azam is Vice President of Medical Affairs at the Patient Access Network Foundation. Welcome to you both. Let me just start out with Dan. Dan, as I understand, Avalier is kind of a collective, an aggregated, smartest people on the block on how to make healthcare work. So when it comes to the experience we're going through now on COVID, and as we ramped up to it and saw the stress and the realization that we had dependencies, we had shortages, what do your team of people think we need to do to not relive this history?
Look, first of all, thank you for recognizing Avalier. I don't know if I would call it a collective with all this discussion of China, but it's a group of very bright people who are doing analytic work around healthcare. And look, I think it's really important for us to think critically about where we need to protect our supply chains and where we don't. Because what we don't want to do is make generic medicines in particular less accessible to consumers. Already, we see really kind of a brewing crisis of availability in terms of people being able to access generic medications inexpensively. Seems like they're getting more expensive with every passing year, and we want to make sure that they can be produced in countries where they can be produced inexpensively. Then there are other things like, critical medicines that we will need to deal with COVID, and we have to make sure that those are produced here, PPE and the like. We have to make sure that those kinds of things that we need that might be hard to get from another country are available to American citizens.
Dan, what you just said was very important about producing inexpensively. We haven't really been addressing that in today's show on the question we've been talking about. There are parts of the supply chain that maybe you have to come back here. You have to get the international and domestic side of this right. But when you are reshoring, when you're creating a different regulatory and cost structure, you're going to drive up prices, right? Somebody's going to pay for this.
Yeah, that's exactly right. And look, I think that Adam Bowler's office thinks about this a lot, and it's part of what they do on a regular basis. But the other thing I think to keep in mind is that yes, some medications are being produced in China, but they're also being produced in Israel and in Pakistan and in really kind of the full gamut of countries, and they're also produced right here in the United States. So it varies, and we just have to be careful that we are selective about designating what needs to be produced and distributed in the U.S.
Aisha, you and your organization are very focused on patients getting access to the drugs, the therapies, the medical supplies they need. How has COVID affected that terrain?
It's had an extraordinary impact, especially from a financial perspective. At PAN, we support nearly 100,000 people per year, and in the last few months, we've seen the number of people who've come to us for assistance skyrocket. I've heard from a woman with MS a couple of weeks ago, and she said, the stimulus check and that allowed me to get through these last few months with the mere basics. But as I look ahead and into the fall, I don't have resources. I don't have any savings because I've used it all, and I don't have any hope of what my future will look like. And that's what we're hearing on the regular, that the safety net is not big enough to be able to help patients who are seriously ill, especially those on Medicare.
So I know you are in a way that what your network does is it provides some subsidy to folks and help them pay those bills, those expenses. But when you are you're a huge organization, so when you are interacting with governments, what counsel do you think those governments need to hear about this time?
Sure. So one of the biggest things to keep in mind is that our goal is to provide financial assistance to people with serious illnesses so that they can become healthy and stay healthy. And we advocate for increased access and affordability. So some things within the government and the healthcare structure that make it very, very challenging for patients to be able to secure access really have to do with how the Medicare benefit is designed. Regardless of how you look at it, patients have exorbitant out-of-pocket costs, and often those costs are unproportional throughout the calendar year. And that seasonality of having higher costs up front really prevent patients from being able to even start treatment, let alone remain adherent.
Thank you for that. Dan, when it comes to, one of the things I've always thought about, and this is probably a little bit off script, but when I think about the costs of healthcare and I think about what people are experiencing out there and how to kind of get it, we often are looking, for one villain, one problem. There's a big ecosystem. There are insurers, there are pharmacy benefit managers, there's the government, there are productions, there are generic firms and pharmaceutical research firms. And so I'm just interested in your insights in this time, because sometimes times of crisis are the right times to rethink this. In terms of getting high quality care at a level that we can need, are there things that you think we need to adjust that we don't have right in that ecosystem?
Yes. So it's a great question. And I think the most important thing is that all Americans have access to accessible health insurance. And you look at this country today, and that's just not true. And what we're seeing is disproportionately, this is affecting minority communities of color, much more selectively than white communities as well. And so, we have a situation in the United States where the most important thing that we can do is just make sure that everybody has health insurance, and particularly in communities of color. So that probably means expanding existing programs that we have, and just making sure that, particularly in this time during this crisis of COVID, that people can access health insurance easily.
And can I ask you also, there's been a lot of, I don't know what to call it, a lot of growing fear, tension in the U.S.-China relationship. I would need to remind people, China today is still America's largest overseas trading partner. So if you were to wipe out that trade overnight, which we're not about to do, it would have a staggering impact on GDP and quality of life in the United States. I'm just interested how in this kind of growing tension, this simmering relationship, how do we not throw the proverbial baby out with the bathwater as we think about onshoring? How do we not walk away from global opportunities, global relationships that make sense? So, and we may have to make some nuanced shifts, but I'm just interested in your insights on that. And that's really what's at the core of the supply chain discussion.
Yeah, we just need to be selective, and so to give incentives for, let's say, N95 mass production in the United States, very important. Something we should have done it a long time ago, and we should accelerate that. To require that generic Lipitor or atorvastatin, just to use an example, is produced in the United States, that just doesn't need to happen, And so there has to be a framework that is selective so that it doesn't drive up patient costs, and that it protects American interests. And I think that so often what happens in politics is that if you have an idea, it can extend out and people can use it to kind of push another agenda. And our healthcare system doesn't need another cost driver, and that's really what we need to balance here.
Thank you for that, Aisha. Let me ask you something from your perspective. Does the PANF, Patient Access Network Foundation, does it cover other parts of the world, or is it just the United States?
So PAN covers the United States as a whole. This year alone, we've been able to help around 80,000 people, and across all of the different charitable foundations that are regulated by the OIG in the U.S., we help nearly 500,000 patients per year. But the Medicare industry is so much bigger, especially those that are of low socioeconomic statuses. So, we're unfortunately, while we are able to help lots of folks, we're not nearly able to help enough of those who actually need it.
Well, I think, the reason I was asking that question was to get a sense, and again, this is going to be an unfair one, that I think a lot of times when you have a large organization and you look across lots of communities, the question is, can't one size fit all? Can we make, one thing work in everything? So I'm just interested, as you sort of looking out the healthcare realities for people and what you're trying to do, are you finding it's different in rural areas versus cities versus ethnic groups? Are there insights that you're getting? Because I imagine that one size does not fit all in terms of responding to this, unless you want to tell me I'm wrong.
No, that's completely true. And one of the things that we've noticed most is, we often look at things by disease state because we're helping patients with different diseases across the U.S. However, regardless of the disease, patients that we're helping, we're seeing that socioeconomic disparities across the U.S. We're seeing how that's greatly affecting someone's ability to not only take their medication, but meet basic food needs. And recently, we did a survey to patients who are receiving financial assistance from PAN and asked them, how has COVID affected your basic health needs? And how has it affected your social determinants of health? And 1 in 3 have found that because directly of the COVID pandemic, they've had a much harder time being able to secure just basic resources and be concerned about it. And so we definitely do see in rural areas and in more urban areas as well, there's a much bigger need for assistance. But the most challenging part of that sometimes is being able to raise awareness and make sure that those patients who are looking for assistance are connected with the right resources and able to speak with the healthcare providers and pharmacies who can guide them to appropriate referrals or financial assistance resources that may be available to them.
Oh, thank you. And then back to Dan. Dan, I would ask you, a similar question. If we get Dan up there, I know you talked about insurance and getting more Americans covered with quality insurance in this. But are there other dimensions? I mean, in part, we've got again another balance issue. The social contract between research and innovation. With new drugs and whatnot is, I think, an important part of the health ecosystem. But there's a social contract with the generic industry. We heard Brendan O'Grady earlier talk about the savings that have been delivered from generics. But I know that those very thin margins, I mean, I've kind of looked into the economics of it. What are we getting wrong? What can get better? Because it sounds like, you look at the different price factors, generics are helping a lot, but it's still not doing enough.
Yeah, we have to make sure that there aren't impediments to bringing these generic drugs to market. And the impediments, look, there's a very legitimate and important role for the protection of intellectual property in this country, full stop. But after that patent expires, that generic medication should come to the market rapidly. And it's also important for the second generic in a particular class to come to market so that there isn't undue markup on the first generic. So that's kind of another aspect of it. And I think that over time, look, the FDA is focused on this. They are aware that in order to have marketplace competition, you have to have these generic products come to market rapidly. And then I think it's really important to make sure that insurance companies make the generic drugs available to consumers by not putting them on high tiers. And one of the things that we have seen over the last few years is that insurance companies are marking up these generic products more and making them more difficult for consumers to get the generic products. So that's another thing that I think we can do better.
Let me just ask you one other dimension on this issue of supply chains, which is, become a hot topic, and people are out there looking at it. Are there ways in which we should be thinking about how to tie up and become more closely coordinated with clear, allies? Maybe India is not an ally, maybe China is not an ally, of course, but there are countries. I mean, an enormous amount of APIs, for instance, are produced in Europe. I think about 28% are produced in the United States, but a lot of APIs in Europe. Should we be looking at that, become more aware and literate with that, Dan?
Look, I think that the commercial markets are working well when we let them. And that's, again, something that I think Adam's office has focused on quite nicely. So I'm not going to say that we should be kind of jumping into these commercial relationships, but I do think that making sure that generics get to market more rapidly and making sure that we are protecting those products that we absolutely need to have in the context of a pandemic or a crisis to make sure that that supply is available domestically. That's really where we should be focusing our time.
And let me come back to Aisha. When we're talking a lot about trying to make the overall health ecosystem better than it is, and I know that you're looking at the patient dimension of it, patient advocate. I'm interested, do you have any insights what the rest of the ecosystem needs to hear?
Yeah, I would say, with regards to generics in particular, it's a great idea, and it's something that can help so many patients, but it's not a complete answer, specifically because, drug discovery does take a long time, and still, often those generics can be very high cost. At PAN, we cover both brand and generic drugs in all of our programs, and often the costs are sometimes just as high as the branded products. But overall, within the industry, what kind of solutions could help patients? One is updating the Medicare Part D structure, two, smoothing patient out-of-pocket costs, so those split proportionally throughout the year to keep patients adherent, and then capping costs so that, after a certain point, patients are not incurring the costs and being able to have the short chain make a decision whether it's about being able to take their medication or put food on the table.
Wow. And let me ask you both, as we're thinking about this, and we're, getting into our next guest is about to come in. And so thank you for letting me enjoy a little bit more time with both of you. But I'm, interested again in as we, just talked earlier with Adam Bowler, we talked with Senator Chris Murphy about, ways of rationalizing this. And I'm very, very aware that in terms of getting the global scene right and the domestic scene right, part of it is restoring trust and making sure that as we see either a next wave of COVID or we see, God forbid, another pandemic or terrible epidemic hit America, do you think that, Adam, you used to work at the Clinton White House. From what you're observing and seeing either with legislators or with the executive branch, beneath the noise, are we doing the right things with our allies and our trusted parties in this conversation?
That's a tough question. Look, I think that, first of all, I want to agree with what Aisha said about the access to the branded medications as well. The work that the Patient Advocacy Foundation does is absolutely critical to enabling patients to get these medications. And then there are a whole range of things that health plans are doing to make sure that patients are compliant with medications, which are also very important. And Medicare can do more to stimulate that. Look, with respect to how we're positioned right now with our allies, it's a difficult situation because, of course, COVID-19 is a global pandemic, and we're all in this together. And I think a lot of our allies are looking over at the United States and frankly wishing that we were on top of it faster and that we were doing more and that we were kind of engaging much more aggressively with mask use and social distancing and the like to get our numbers under control. So, from my perspective, I guess I don't think that we've done ourselves a lot of favors in the world with respect to how we've positioned around COVID-19.
Aisha, I would love to hear your comments on vulnerable communities, communities of color, the unevenness of how COVID has hit the world you deal with. What are the, what does that look like from your perspective of those folks who need support? And I know you can't do all of this on your own. And I sort of, want to ask this is, I know you don't have the resources you need to cover everything up. What else should other players in the ecosystem, in government, in private sector be doing to help alleviate the burdens you're seeing out there?
Yeah, definitely. One of the bright spots in the entire pandemic is that people are talking about the inequities that patients are facing, both from a socioeconomic perspective, understanding how systemic racism is playing a role within people being able to secure basic health resources and being able to receive proper medical care and attention. And so that is definitely something that, unfortunately, while social determinants of health for all patients has been kind of in a downward spiral, we're now in a situation where many more people are talking about it and keeping it top of mind as they go forward in making decisions. My recommendation overall is to provide support, whether it's advocating for changes within the healthcare industry and making it so that health plans are making sure that patients are not having as high out-of-pocket costs, and that it's not coming back to like the health insurance premiums if it's not coming on the end of them paying copays or deductibles. But then also making sure that organizations across the board, both at a public and private level, are having the conversation with everyone to make sure that folks are aware of the different kinds of resources out there and they can access them as they become available.
Well, thank you for that. Aisha Azam, Vice President of Medical Affairs for the Patient Access Network Foundation. It sounds like you're doing truly heroic and important work for a lot of people in need, so thank you so much for that. And Dan Mendelsohn, founder of Avalier Health, which is not a collective of innovative thinkers, solving the problems of health, but rather a community. And so, Dan, thank you so much for joining us and sharing your insights.
Thank you.
Thank you.
My final guest this afternoon is a former member of Congress. Mike Rogers served as the chairman of the powerful House Permanent Select Committee on Intelligence during his time in office. He and I have discussed global supply chains, the national security dimensions, and how we get these equities right. So I hope Mike is with us. Mike? Let me see. We're going to jump to a chart. Let me show Mike this chart. Today's my day for using charts. So in this one, chart 3, the chart lists facilities for 370 drugs marketed in the United States based on the WHO's, that's the World Health Organization's, essential medicines list. Where do these essential medicines come from? Well, 21% of them come from the United States, and 15% of them come from China, and the rest of the world covers the remaining 64%. I wish we had some more breakouts, but that shows that America has a big footprint, but China has been growing like crazy in this, and then we've got a lot of others there. Let me just ask Mike Rogers, who's hopefully with us, whether he would like to redraw any of those lines on that chart.
There we go. That is perfect.
There he is.
What I'm going to do is I'm going to put you through the studio, okay?
Okay.
Do we have Mike with us? We are having some technical difficulties. And well, I will tell you, because even I had the impression, learning it myself, I sort of learn on the wing, the fly here sometimes. I thought that much more had moved to China than had. And so the United States has a significant portion of API and drug production in this country. A very large amount continues to be in Europe. In fact, with our sponsor today, I know about a third of drug production, that's done for the U.S. market comes from the U.S., third is from Europe, comes in, and then others like India, China, and other places. And so the question is whether those lines are worrisome. So I think Representative Rogers is with us. Mike?
Yeah. Yeah.
So this is not working. Is Mike Rogers with us? I don't know what to talk about here right now, so give us just a second, folks. I apologize. We have a connectivity issue. We are still trying. I think we're going to have to end the show, and I am sorry for that trouble. Let's go to the end, please. We're sorry that we weren't able to bring you Mike Rogers today. He's a fascinating person with great insights and views on how to kind of get the equities right for not only the health and medical supply chains coming into America, but also a kind of broader set of this, and whether or not we need to have a review, an annual review that looks at how to do this smartly, but also understands you can't wave a wand and just make this stuff happen. It's going to take a serious bit of work, industrial planning, financing, as we heard from Adam Bowler today. Well, that brings us to the end of our program. I have a big thank you to Tefa for their support, and to all of you attendees for joining us for this very important discussion. For those of you who missed any of the conversations this afternoon, we will have the video up from our event up on our website shortly. I'm Steve Clemens. Be well.